I'll get on to institutional medicine. The institutionalization of all aspects of medicine is now established fact. Within each institution, the healthcare team is essential in the practice of comprehensive medicine. Physicians and non-physicians now cooperate in providing the spectrum of medical services made possible by modern technology. Competence, confidentiality, integrity, and personal concern are far more difficult to assure when such diverse professionals have varying degrees of responsibility and contact with the patient. Thus, the most delicate doctor's responsibility, protecting the patient's welfare, must now be fulfilled in a new and complicated context. Instead of having the more traditional one-to-one relationship, the physician is the coordinator of a team, sharing with others some of the most sensitive areas of patient care. The physician is still bound to see that the group assessments and management are rational, safe, and personalized. The physician must specially guard against the dehumanization that can so easily be perpetrated by a group in the name of efficiency and collective responsibility. The doctor must acquire new attitudes. Since ancient times, he has been the sole dominant and authoritarian figure in the care of the patient. He has been supported in this position by traditional ethics. The traditional ethics has now to be tempered by the new concepts of patient autonomy and patient rights, enshrined in international conventions and covenants. In the clinical emergency, the role is still unchallenged where the doctor is concerned, because he is supposed to be well-trained to make quick decisions in ambiguous situations. He is also not prepared but he is also not prepared for the negotiations, analysis, and ultimate compromise fundamental to group efforts that are essential in non-emergency situations. The whole new set of clinical perspectives must be introduced, perspectives difficult for the classically trained physician to accept, but necessary if the patient is to benefit from the contemporary technology and organization of healthcare. Therefore, as stated in the Declaration of Health by the Sri Lanka Medical Association in 1995, patients are entitled to be referred to an appropriate professional or institution when referral is indicated, be competently and adequately assessed by their medical professionals, and request and receive second opinions when appropriate. So therefore, in the context of institutionalized medicine, a whole new set of ethical guidelines have to be created, and I am aware that there are no such institutional guidelines for the practice of medicine in institutions that is prevalent in Sri Lanka. I go to truthfulness. This is a fundamental and universal virtue for all human beings, but it is more important and more so for doctors. And John Donne, who was a poet and a satirist, a lawyer and a priest, and for a long time I thought he was also a doctor, said this, almost an early warning. I observe the physician with the same diligence as the disease. At the core of the doctor-patient relationship must lay a feeling of trust between the two. If a patient does not trust his or her physician, then the doctor's effectiveness is greatly compromised. Patients must know and be convinced that their physicians have their best interest in mind, and telling the physician the truth about their illness and progress is important. The physician must also ethically be obliged to report the truth to the patient, the exact extent being debatable in different socioeconomic and cultural contexts. The history of literature on medical truth-telling dates far back. Thomas Percival, one of the earliest medical ethicists, true to the paternalistic ethos of the time in 1803, said, to a patient who makes inquiries which, if faithfully answered, might prove fatal to him, it would be a gross and unfeeling wrong to tell the truth. And I think we do practice Thomas Percival's position even today. Some doctors do not tell the truth to their patient because they believe that telling the truth to the patient, particularly a terminally ill patient, the truth might, if not necessarily fatal, might have a negative impact on his psychology and on his life expectancy. So I think many doctors today stick to Thomas Percival's argument that telling the truth might not always be in the best interest of the patient. But there are other arguments. This is contrasted by a more modern doctor, Saul Radowski, who says that doctors are not wise enough to tell in advance who should be told, and that shielding is ultimately impossible. The price of a temporary achievement is an enduring sense of betrayal. Once lied to, even supposedly in their own interest, people will not trust their doctors fully again. So therefore, the doctors today are faced with this dilemma. To tell the truth, how much of the truth to tell? Not to tell the truth, hide it completely from the patients and only tell the next of kin or relations? Or to tell the truth to the patient, which the patient may not be fully prepared to accept. So that's a dilemma that persists even today. But the modern trend in medical ethics is to work out its principle from the standpoint of the supremacy of the patient. As I said before, the doctor is no longer the decision maker but only the counselor, who will create the necessary space for the patient to take the decisions. At this point, I might intervene with a cautionary tale, particularly because of the KDU, and we have a lot of military doctors in the KDU. We know that after the Second World War, there was a Nuremberg trial where the Nazis who lost the war were brought in for war crimes. And today, since we are talking of war crimes in Afghanistan, in Iraq, in Sri Lanka, it might be appropriate to remember that there are issues that some people will tend to bring up when the time seems appropriate for different kinds of national, international, and other interests. But we have forgotten, or most people don't know, that at the same time or immediately after the Nuremberg trials, which were highly publicized, there were special separate trials for doctors who supported the Nazi regime. There were doctors' trials where doctors who were involved in totally unethical experiments with patients, with people who were incarcerated in concentration camps, were later found to have been performing torture and inhuman experimentations with the prisoners. Dr. Mengele, who was the famous of them, escaped the during the final phases, and he, I think, hid in a South American country for about 40 years until he was discovered in the 1990s and taken back to Germany and sentenced for life imprisonment. So these are issues that might be pertinent, particularly in the context of military medicine. We in Sri Lanka have a long way to go in establishing some of the norms or basic tenets of modern medical ethics. And I have briefly mentioned in the preceding paragraphs that we need to go to some of these tenets in modern medicine quickly and surely before we become, by default, an intolerably medically litigious society. I leave the following thoughts with you from Scott Buchanan, an American philosopher who died as recently as 1968. He said, "Medicine stands at the head of natural sciences and does not know which way to go. It has a record maximum of knowledge and a minimum of understanding. It has art and wonders if it has science. It is suffering from an intellectual imbalance of virtues." Thank you.
Yeah. I was so engrossed by what he said and so absorbed that I forgot to keep time. He exceeded it slightly, but to our benefit. Thank you.